Hello, this is Dr. Turkmani, and I would like to start thanking the organizers for the invitation. This lecture is about how to tackle corneal perforations and newer trends to solve this problem. I have no financial interest to disclose relevant to this talk. As we very well know, a corneal perforation is an ocular emergency and it can arise from many different etiologies, from trophic corneal problems to infectious disorders, rheumatological disorders, traumatic disorders, and sometimes we may never find out why this patient presented with a corneal perforation, which we would label as idiopathic or unknown. We can also classify corneal perforations based on their size. There is no official classification as such, but there is a common agreement that less than 2 millimeters we would consider small, 2 to 4 would be medium-sized perforation, and more than 4 would be what we would consider as a large perforation. In terms of location, they can affect the central cornea and they would have a greater visual impact. They can affect the paracentral cornea, which, depending on the size of the perforation, may have a greater or lesser impact in vision, and then peripheral perforations, which usually have a lesser impact in visual acuity. In terms of how do we approach these corneal conditions, for smaller perforations we can use a glue patch or amniotic membrane or conjunctival flap. This is usually the approach for smaller perforations, and the results are usually poor, especially if the perforation is central or paracentral. And for larger perforations or central ones, we traditionally have been using a penetrating keratoplasty. However, we know that the rejection or failure rate is greater when we do a PKP in a hot, inflamed eye. There is a greater risk of expulsive, particularly if the hypotony was sustained long enough to cause choroidal detachments. There can easily be suture-related problems, whether loose sutures or cheese wiring, that can lead to leaks and reinterventions. So this is never an ideal scenario to perform any type of graft, but particularly a PKP. So recently we started working on other ways to tackle corneal perforations, and we came with a rather different approach, which was tackling the perforations with thin manual DSEC or normal thickness, let's say manual DSEC, since there is a tectonic defect in here, so we wouldn't push it as thin as we would normally do for a normal DSEC for Fuchs or pseudophakic bullous keratopathy. This is the paper that we have published in Cornea Journal, in which we presented a case series of different conditions and etiologies leading to corneal perforation that we managed with manual DSEC. If anyone is interested in further details on this paper, there is the reference is there for you to check. The principles in which we were relying were that it would plug the perforation from the inside, therefore no need for suturings other than the main port of the DSEC, but certainly no sutures to anchor the graft. Recovery time would be quicker, or expected to be quicker, than that of a PKP for the same condition. We would be avoiding open sky surgery, which we have said it can carry greater risks of expulsive hemorrhage, particularly if there are choroidal detachments in fundoscopy, and also that this is a surgery that can be performed under local anesthetic, unlike PKP, which would preferably require a general anesthesia. These pictures are a case example of a patient that presented with a reasonably large, medium to large corneal perforation, presumably herpetic. You can see how the one-piece rigid IOL was misplaced superiorly. I wasn't very sure whether what was there at the perforation, was it vitreous or was it the posterior capsule? It was difficult to tell. In any case, I took this patient for surgery, repositioned the one-piece IOL in the sulcus, as I wasn't very sure about stability of that lens in the bag as it was, and then performed a tectonic dissect supported by a glue patch, as you can see there, to help with attachment of the graft and preservation of the eye soon after surgery. And then the final picture is several months after surgery, after also the introduction of autologous serum drops to help for epithelialization and patient recovering vision from light perception to 618. So, once we've plugged the perforation, is there anything else we can do for these patients to improve vision, particularly if the perforation is central or paracentral? This question was somehow baffling my head because in one hand I could see so many arguments in favor of doing DSEC basically for almost any perforation. However, if the PKP graft survived, if it didn't fail, if it didn't develop cheese wiring problems, if it didn't develop any of the potential post-operative complications, then technically the visual potential, if there is no involvement of optic nerve or macula, it could potentially be 20/20 or close to 20/20. So I could see that in certain perforations, the irregularity that was induced in the surface could limit the final visual outcome. And then the next question is, can we do then something to improve surface regularity? And then I thought, well, if we can use a glue patch to support the graft, or we can eventually use amniotic membrane, why cannot we use a bummer graft, which has been proven to regularize the ocular surface in cases of superficial corneal opacities related to herpes virus, for example? Cannot we use this from the same donor cornea to regularize the ocular surface in the same procedure? So then, for selected cases, I started doing tectonic DSEC with tectonic pulmonary transplant in the same setting to take care of both the corneal perforation and the surface irregularity. So these pictures, for example, are is the eye of a patient that presented again with a corneal perforation of unknown cause, presumably herpetic, on whom I did a combined DSEC, tectonic DSEC, which is the picture in the middle, and immediately after, in the same surgical procedure, I performed a tectonic pulmonary transplant to give better support to that DSEC graft than a glue patch would provide with, plus take care of the surface irregularity. In the OCT, on day 1, you can see the different layers. At the very top, there's a bandage contact lens. Underneath, there is the pulmonary graft. You can see it's thickened, and very interestingly, is even more thickened in the areas where you have more irregularity of the underlying stroma. So, of course, that is not because I've got a graft of different thicknesses in different areas that match perfectly the areas of irregularity of patients' host stroma, but rather there has to be some degree of remodeling of the tissue in the interface, new collagen formation, and even tissue edema and other factors that may give rise to this sort of lock and key match of the different tissues. However, you can see that the surface right under the contact lens is very smooth, much smoother than what it would have been if it was the DSEC alone. Then you can see that the remainders of patient's own stroma are sandwiched between the pulmonary graft and the DSEC graft, and finally you can see the DSEC graft at the very bottom, plugging very well the perforation, and those opacities you can see in the anterior chamber are fibrin from the inflammation that had been triggered from the original condition. So in summary, tectonic DSEC is a very useful strategy, even for larger perforations. It has even evolved into other techniques that our colleagues in Moorfields Eye Hospital are doing for different size perforations and named as tectonic mini DSEC. If necessary, it can be supported by a glue patch or amniotic membrane transplant, but even it can be supported by a bummer layer graft. in which case it would serve as treatment for the perforation itself and also the surface irregularity. I hope you enjoyed this presentation and thank you very much for your attention.